Everyone. My name is Olivia, and for my capstone project, I studied the determinants to participation among veterans experiencing housing insecurities. My capstone was completed at the VA Central Iowa Healthcare System, and specifically, I was in the Extended Care and Rehabilitation Service line. But my study was completed at the Community Resource and Referral Center, or the CRRC, and that is a satellite location in downtown Des Moines, Iowa, that serves those who are homeless or at risk of becoming homeless. And the center provides a lot of different resources like showers, laundry, and some of the other things that I listed on the screen. And they also house the program offices for the HUD-VASH and GPD programs. So HUD-VASH stands for Housing and Urban Development VA Supported Housing, and this program provides housing vouchers and other support services to eligible veterans so that they're able to gain permanent housing. And GPD stands for Grant and Per Diem, and it's a program that provides financial resources to agencies who provide services or housing to veterans. And again, this is to support them in gaining housing stability and also developing some life skills. At the CRRC, they also have 2 certified peer support staff, a nurse, mental health therapists, and employment specialists. And they have various group programs that they run. And one of them was the Healthy Living Group, which I was involved in running as part of my experience there. The population that we served was veterans experiencing homelessness or housing insecurities, and within that we saw a wide variety of mental health diagnoses. So the current problem is that veterans throughout the country and in Iowa are at high risk for experiencing homelessness. And research shows that this population faces many challenges, including mental health conditions, substance use disorders, and difficulties with job attainment and community reintegration. And so this heightened risk, paired with the functional implications, indicate that there's an occupational injustice present, and then falls within the occupational therapy scope of practice to address. So to provide a little bit of background and context about the study, the VA defines homelessness using the Homeless Emergency Assistance and Rapid Transition to Housing Act, or the HARTH Act. And this defines homelessness as a person who does not have regular or adequate nighttime residence. So this could include people who may sleep in their car or sleep in public spaces like a park, or those who are currently staying at community shelters. And so the goal of HUD-VASH is to transition those individuals into a permanent housing solution using the Housing First model. And as I just mentioned, veterans are at a much higher risk than non-veterans for becoming homeless. And among this veteran population, veterans who currently have a mental health condition or a substance use disorder are at even higher risk than the general veteran population of becoming homeless. And one study found that only 10% of homeless veterans were employed, which also kind of supports that unemployment is another relevant factor. And so the current mental health OT is very limited in terms of her time and personnel that's needed to be involved at the CRRC. In addition to those limitations, the group programming that's currently run at the CRRC is significantly limited in attendance and participation. And another aspect I think is really important just to note here is that other CRRCs around the country have either part-time or full-time occupational therapists on staff that have had positive outcomes. So with this in mind, I kind of started to wonder why this site did not have a fully integrated OT, and why I wasn't able to see more participation at the groups that were being run. So, referring back to our historical foundations and to our current code of ethics and the scope of practice, all of these indicate that it's appropriate and falls within our occupational therapy scope to address things like ideals of community mobility, work, and home maintenance, and things like that in order to promote occupational justice. There's also been multiple studies that have shown positive results when working in homeless shelters and when running groups based on life skills. And getting a little bit more specific to my study, one study that was at a supported housing facility found that there were discrepancies between the barriers that staff members perceived about the lived experiences of the residents. And so the staff really tended to perceive more personal barriers to obtaining independence and employment, whereas the residents of the supported housing facility reported more environmental barriers to independence. And this last blue box on the right here was an article published by the Veteran Health Administration National Homeless Program Office, and it stated that OT has the skills to support housing maintenance once a veteran is housed within one of the VA programs. And it also cited specific CRRCs in which OTs are currently working and having positive outcomes. So with all this evidence supporting the integration, there's a clear gap that OT is not fully integrated in the Des Moines CRRC. And there's also many factors influencing the participation at the CRRC that haven't been identified. So my study was kind of seen as the first step in identifying these factors so that occupational therapy could then use their modification and adaptation skills in order to promote participation. So the conceptual framework that I used to develop the study was the model of human occupation. So within this model, there are three main components of the person, which are volition, habituation, and performance capacity. The model also acknowledges various aspects of the environment, including the physical, social, and cultural aspects. And I chose this because it's a systems-based model, and I like that it acknowledges how any of the components of this model can impact other aspects and then thus influence change in the overall outcomes. And really, I use this model to frame how I was thinking and processing through the literature and developing strategies for data collection. So my overall experience objectives were, one, to develop a project to identify the needs of homeless veterans and the current barriers to group participation. And this one was the one that was really targeted at my project. The others were to identify methods to increase access and sustainability of the programs for homeless veterans, and then also to identify the role of occupational therapy at this center, and to identify the impacts of mental health and substance use on occupational participation. So my research question is, what are the barriers and facilitators to group participation among veterans receiving services at the CRRC? And specifically, I wanted to identify these determinants to participation by conducting semi-structured interviews. So the study was a quality improvement study, and we decided this because the results were intended to be used to improve the current group programming at the VA and not to be generalizable to other settings or populations. And also because the interviews were conducted and determined that they did not pose a risk that was any more than that of standard occupational therapy practices. I used convenience sampling at the CRRC with the help of the staff in order to identify the veterans who met the inclusion and exclusion criteria. And I ended up with 5 participants. The instrument that I used to collect the data was the semi-structured interview format, which I developed with my site mentor. And I took notes during all of the interviews on things like keywords or phrases that the participants said. And I also tried to gather a few meaningful quotes during the interviews as well. I also did not collect any identifiable data as just another measure to maintain the confidentiality of the participants and to abide by all the VA policies and standards. Bracketing was also completed with both my faculty and my site mentors in order to try and mitigate any of the biases that I have in the study. And so this was done through discussions with both the mentors about what my biases are, such as being an occupational therapy student, having only other occupational therapy students on my research team, and not having any interprofessional team collaboration. And also, one big bias was that I was completing my capstone experience simultaneously while completing the research. So thematic analysis was completed using a mixed method approach. So we used parts of grounded theory. However, we're not able to use this theory in its entirety because the interviews weren't quite as in-depth as what would be needed to develop a theory. So the interviews were transcribed from the notes that I took, and then the 4 members of the research team the research team first coded by just reading line by line and taking notes, and then from that developing these kind of low-level initial codes. Then after those were developed, I met with my site and faculty mentors to review everything and start to consolidate into larger categories. And after I developed the categories and kind of defined them, defined which of the initial codes fit into each category, I met again with my mentor to go over those and to make sure we agreed upon everything and there were not any discrepancies. And then from that, we developed these kind of 3 overarching themes that, again, we agreed upon, and then the whole research team agreed upon too, as in a way to validate the data analysis process. So I ended up with 5 interviews, as I said, and the 3 main themes that were developed were personal aspects, organizational participation, and the organizational environment. And each of these were then kind of split or divided into what could be considered a facilitator and a barrier to group participation at the CRRC. So this first one, personal aspects, included things like attitudes towards participating and knowledge about OT, and also about the name of the healthy living group. And so the attitudes towards participating can either be a facilitating or a barrier. One of the participants noted that they were really open-minded, and so this could be seen as a facilitator, whereas those who are more indifferent to participation could be seen as more of a barrier. And then the next theme was organizational participation, and this was defined as any activities or occupations completed either at the CRRC, as well as those that were completed at the main VA site and at other community settings. And any of these activities that impact the level of participation at the groups held at the CRRC. And so this included things like all the activities that were offered at the CRRC, so things like laundry and showers, and all the therapy appointments and case management and any other appointments that they may have had. And these could either be facilitating factors by increasing the regularity at which they were visiting the center, or it could be seen as a barrier because if they had so many other kind of priorities and activities that they weren't able to participate in the groups. And then the last theme here is the organizational environment, and this is relating to all the different aspects of the environment that that influence participation. And so almost all of the participants brought up scheduling as a challenge, and other things that they discussed in that fell within this theme were things like transportation and the physical environment, and also just kind of the group format and group dynamics, and also the lack of advertising of the groups, and also housing changes. And these can all be seen to have an influence on whether or not they were able to attend and participate in the groups. So all of the themes really tended to focus on either an internal or external factor that impacts participation. And so by identifying some of the determinants to participation in the groups, I was able to connect how occupational therapy is really well equipped to address and kind of problem solve some of these factors. And this also just provides additional support to the expansion of OT at the CRRC. And identifying these factors, again, just serves as kind of a first step to improving the groups that are run there. And it also allows us to reflect on the current group, the current topics of the groups, to really see if we're really addressing the needs of the veterans. Some of the limitations of the study were the small sample size, the organizational restrictions that limited the data that I was allowed to collect, and the fact that the information is not generalizable. And another huge, very large limitation was the impact of COVID-19 and its impact on participation. And this was not able to be reflected in the interviews because they were completed before Iowa saw very many cases and had much of an impact. But I still think it's really important to acknowledge the impact of COVID-19 has on the participation, specifically because the CRRC is currently closed, so veterans are no longer able to visit that center. So as occupational therapists, we have an ethical responsibility to try and address some of these determining factors. And I also think that some of the factors like decreased knowledge in the various aspects of health and even more general decreased knowledge of occupational therapy allows us the opportunity to be able to advocate for OT and also educate both the veterans who are coming to the center and the other staff about how OT, about what OT is and how it can fit into the services provided at the CRRC. And also something that has kind of already started is modifications to the current groups. So for example, we have already discussed changing the names of the group instead of having it the Healthy Living Group, changing the names to make it more maybe understandable. And additionally, we've discussed moving the group to a different location to try and mitigate some of the barriers as well. And I think an important next step in kind of improving these groups is reviewing the topics again, and just ensuring that they're really relevant and meaningful to the participants. And also there are some environmental modifications that can be done in terms of how the room is set up at the CRRC, the room that it's currently held in, and also just some different ways to advertise the group and just display what's being offered. So some of the lessons that I learned, this definitely is not an all-encompassing list, but I think it's really important to acknowledge my bias, and just acknowledging bias is really an important aspect of qualitative research. I also learned kind of more about the interviewing process and how it can really be time-consuming at times, and also it's really important to kind of acknowledge the way you're asking questions, because the way you ask questions may be influencing the respondent's answer to the question. I also, I think I already knew that advocacy was important, but this really showed me how important advocacy is, especially in non-traditional settings. And I just think it's so important to be able to articulate why our profession is unique and valuable, especially in these non-traditional settings. I also think that flexibility, again, is just so, so important. And I know that many of our projects were completely changed. Mine especially was. And then also with the termination of all the in-person rotations due to COVID-19, I think we all just had to be really, really flexible in how we were able to complete the project and complete the experience. And so as difficult as the experience was, and as much as COVID-19 has impacted us all, I think it's just given us another opportunity to practice our adaptation and flexibility skills. So before I end, I'd like to thank the CRRC and the VA of Central Iowa and all the staff there for all their support and encouragement, specifically my site mentor, Sarah Reinick, and my faculty mentor, Steve Taylor, for all of their help with data analysis and collecting the data, and also just working through the manuscript process. And I'd also really like to thank Paula Costello and Linda Olson just for their support throughout the entire Capstone experience. And so here are my references, and thank you so much for listening.